We have Dr. Drolet who's with us today. She's from our other newer clinical care network, and she's going to talk to us about dermatology. Thank you, Dr. Drolet.
Thanks, Julia, for having me. Good afternoon, everybody. So I have a few slides and pictures, but also hope to leave it open for questions about the skin as well. So I'm going to share. Hopefully this will work.
Looks good.
Okay, let's see. Okay, so what I thought I'd do is maybe just give some basic information about what we know is happening in the skin. This is some of our funding that we have for vascular anomalies, and very grateful for a grant a couple of years ago from the Sturge-Weber Foundation. So as everybody on this call knows, really the first thing that parents notice and doctors notice in children with Sturge-Weber syndrome is the skin changes. And there are a few different names for these skin changes, capillary malformation and port wine stain, port wine birthmark, all in my mind kind of are the same thing. And so these are considered blood vessel or what we call vascular birthmarks affecting the skin. We know that they're vascular, without doing any fancy testing, biopsies, or imaging, just kind of by looking at them, by the characteristic bright red to pink color. And then, one of the easiest ways to be sure that it's a blood vessel birthmark is we just push on the skin, and if we can blanch the color and then it fills back up, that we know that there's extra blood vessels in the skin. And in this particular instance, they are small blood vessels in the very top layer of the skin, which we call the dermis. And these blood vessels, I think, have been thought traditionally to be capillaries, but I think they may be a little bit of the vein component of the skin as well. So sort of where the capillaries kind of turn into the vein, or venules is what we call them. Capillary malformations come in different shapes and sizes. So although they all are kind of that pink to red color, there are some differences. And I think this is one thing, at least as a skin doctor, that has really changed for us over the last maybe 10 to 12 years, is not everything that's red in the skin is Sturge-Weber syndrome. And so there are actually several different types of blood vessels that can affect the skin that can look like a capillary malformation or port wine stain. And one thing that has really, really helped us a lot is doing genetic testing on the skin to know which gene might be mutated or altered that's causing the excessive blood vessels in the skin. And then knowing that gene can really help guide what might happen to the skin, but also what other organs might be involved, like the eye and brain in Sturge-Weber syndrome. So I put this picture up because, to a pediatrician or somebody in a newborn nursery, these all would look like port wine stain or capillary malformation. But now to my eye, they really are different types of vascular birthmarks. And now we can know that these all four of these children have different causes of the birthmark, and actually different genetic alterations in their birthmark. So I think one of the reasons we've had so much trouble understanding Sturge-Weber syndrome and other vascular syndromes is the terminology that the doctors use and our textbooks use, and now the internet and TikTok use, is not very precise. It's not as precise as what we see in other fields of medicine, and that has kind of slowed the pace of understanding of why some kids and some adults have this problem associated with their birthmark. But I am here to tell you that that has changed pretty significantly with the opportunity to kind of understand the genetics of it. And that's sort of my area of interest in research. So I think I might just go into that a little bit and then we can stop for questions. So when we think about why doctors create classifications, it's really because we're confused. And we see patients that look the same, but then over time, they might have different problems. That one might have seizures, one might not, one might have glaucoma. And so we try to organize these patients and the patient's findings into a system that makes sense. But we all know that biology and human nature really sometimes doesn't follow these classification rules. So I just put this in here because I'm sure everybody on this call that has a child or a family member with Sturge-Weber probably has heard a wrong diagnosis at some point in your life. And part of it is it's really, really complex and difficult. So back in 1982, so right at the beginning of my medical career, there was this big aha moment where we differentiated blood vessel birthmarks into two things: hemangiomas and vascular malformations. And infantile hemangiomas were tumors that grew, and vascular malformations were considered like birth defects of the skin, and they didn't grow and change. And this actually was very helpful. And really, we started to understand the difference between kids with hemangiomas and kids with port wine stains, and kind of started to better differentiate Sturge-Weber from other syndromes that we saw with hemangiomas. And so here is a kind of classic example of what we would call a capillary malformation, very distinct patterning, and that'll be important as we talk about the causes of the genetic changes. But one thing that I would like to point out is that these two patients have the same change in their DNA, but because of the color of their skin, the genes that tell their skin what color to be, sometimes that can look very different. So you can have red marks, and if your skin's darker, you can have these gray skin lesions, which we call dermal melanocytosis. So here's two examples of one, a capillary malformation and a hemangioma. And I was taught that the hemangiomas were tumors, and so that I could use medications to treat them. But malformations were just errors during development, and we really we couldn't use a medication to treat them because it was just like they didn't form correctly, and we couldn't reverse that. And this is probably the most exciting thing if I were a parent of or a family member of somebody with Sturge-Weber syndrome, is that this is actually wrong. And so we do know that the hemangiomas grow, but we also know that Sturge-Weber is a progressive disease. We see progressive worsening of the skin, progressive overgrowth of the lips and the ears. We see progressive worsening of glaucoma. And over time, we see progressive worsening of some of the changes in the brain. And that's bad for patients, but it's also really hopeful for patients in that we can now, for the first time in many, many years, start to think about drugs that might stop that progression. So instead of just lasering the skin and just trying to treat the glaucoma, treating the seizures, or even having the surgeries, we can start to think about drugs that may stop the progression, or even if we're lucky, may actually reverse some of those changes. And I think that is very, very hopeful. We're not there yet, but really providing great hope. So here's all the different vascular syndromes that we see that can be associated with capillary malformation. So I just put this in here just to, again, reinforce that I think it is important to get a genetic diagnosis. And I don't know if I missed the first couple of speakers, but I'd like to just take a few minutes to talk about the genetic changes that we see in Sturge-Weber syndrome, because they are a little bit different than most genetic syndromes. And as everybody knows, these do not tend to run in families. And so this is considered a mosaic, or sometimes what we call a post-zygotic syndrome. So when I went to medical school, we were taught that all of our cells in our body had the same genetic code. Um, and um, and as we've got more sophisticated ways to sequence the human genome, we've found that that is not true. And so that all of us have cells that have slight changes in the DNA. And those changes, at least in Sturge-Weber, happen during development. So kind of simply during development, there's a sperm and an egg, and then they make one cell, which is called a zygote. And that cell has to divide very rapidly during development to make a baby. And sometimes when those cells are dividing so rapidly, there is errors in how the DNA is copied from one cell to another. And so you can have cells that have one change in the DNA. So all of the other thousands of genes are the same, but one gene has one change in its sequence that changes the way that that protein works. And then that cell divides and makes additional cells with that mutation. So that is why we see the patterning, the fascinating patterning that we see with Sturge-Weber syndrome, so that it stops at the middle, because all of those cells that came from that one cell carry that mutation. That's why this eye on the same side is affected, and that's why the brain on the same side is affected. So that's called a mosaic disease, where this side of the body or the face or the brain or the eye doesn't carry that mutation, but this side does. So again, complex genetics, but sort of makes sense when we look at our patients. So we know that every baby that's formed, there's 40 cell divisions. And in each one of those cells, there's about 120 mutations. And that is the cause of Sturge-Weber, as well as many of the other mosaic syndromes that we see. So one of the things that I do as a skin doctor is I study the genetics of the skin changes. And because we're skin doctors, it's much easier to get samples. And so we can take small skin biopsies and use those skin biopsies to extract the DNA and test the DNA. So we have a large group that does this across several centers of dermatologists. Here's all of our partners, and they take skin biopsies from patients with mostly capillary malformations, some other malformations, and then send them to our lab, where we test to see which gene the child or patient might have. We have probably almost 400 patients enrolled now, and about half of them we've sequenced. So just a little bit about the genetic testing, if folks had questions about this. It is not a blood test. So right now, we cannot detect those changes in the blood because they're really in the affected tissue. So the skin, again, is the easiest to test. You can also test the brain if the kids have surgery as well. But usually we'll take a small piece of skin, about 4 millimeters, a little smaller than the end of a pencil eraser. And then we extract the DNA, and then we will sequence that DNA for all of the different genes that we know cause vascular anomalies. And when we do that on patients with capillary malformations, we usually find a gene, not always, but 90% of the time we will find a gene. I would say about half of the time we find the GNAQ, a gene. That's one of the most common ones, the one that is associated with the Sturge-Weber syndrome. But sometimes there's kids that look pretty similar that we find other genes. So here's just the different genes that we test against. And just a couple examples of patients that have capillary malformations or port wine stains that don't have GNAQ. So they have GNA11, which has also been shown to cause very similar changes as Sturge-Weber. So I think is a less common cause of Sturge-Weber. the skin findings look a little bit different, and maybe the brain findings are a little bit different than GNAQ. And then here's a child with PIK3CA. Here's several kids who have the GNAQ mutation. And in the GNAQ mutation, it's always at the same location in that gene, at this 183 spot. And I put this here because this is also a very useful test. So you can imagine if the patient has birthmark on both sides of their face, you can imagine that maybe that cell that got the mutation happened earlier. So instead of when there are 100 cells and just one got affected, maybe it was when there was 20. And so as skin doctors, when we see children that have very large capillary malformations, we worry a lot more about problems with the eye and problems with the brain. And that's been known for a long time. The kind of the larger your facial lesion is, the more likely you will have Sturge-Weber. So here, these first two children have full-fledged Sturge-Weber. This child actually has affected both eyes and both sides of her brain. Really a little bit more problems with some seizures. And this child in the middle had it just on the one side. And then the child without involvement on the forehead really had no seizures and just really had the birthmark, no problems with the eye. And again, here's a child, same mutation GNAQ, but because it wasn't affecting the eye and the brain, it's just a skin birthmark. So again, I just wanted to emphasize how for so long we've been stuck in the idea that malformations don't grow and change. And I think sometimes as physicians, we weren't looking at our patients as much as we should. So you can see over time, there's pretty significant changes. Capillary malformations will get darker. By imaging, we know that their blood vessels are getting more dilated. We know that those blood vessels are getting higher pressure. So it's what we call hypertension in the skin. We know that hypertension can cause dilation in soft areas like the ear and the lip. And so that tissue responds by getting larger and overgrown. So definitely progressive. So I think I'm going to stop here and just see if folks have questions about capillary malformations or mosaicism or genetic testing. And then I might talk a little bit about some of the research that we're doing at UW.
Thank you, Beth. That's great. We've had quite a few in here. It says, does anyone have any idea on what, the mosaic gene mutation? We talked about that a bit. I don't know if there's anything. And Brian and Nicole, do you have any other questions other than what she covered? They do go on to ask, what often is a Sturge-Weber syndrome associated with other diseases listed? Or how often is it?
How often is it? So when I think about how we define Sturge-Weber syndrome, typically is the triad of the birthmark, the eye changes, and the brain changes. Additional findings are actually pretty rare. So it's interesting that it's kind of limited, that we don't see a lot of problems in other organs as well. I will say one thing that we've been noticing in some of our patients is hypertension. And so that's something, high blood pressure, that we want to raise awareness and how that might relate. I kept thinking with all of the other neurologic symptoms to the dehydration and the calcium formation and things like that. But we don't see a lot of problems like in the lungs. Other vascular anomalies we do, and so that's why it's important to kind of differentiate. So really, the tissue overgrowth, and when I think about the diseases in the skin, it's actually so similar and identical to what happens in the eye. Because I think in the skin, the blood vessels get very dilated and distended, and hypertension, I think that's what happens in the eye, which causes the high pressure and glaucoma, and probably what happens in the leptomeninges as well. So kind of the same process happening in those tissues.
Awesome. Thank you. You had mentioned growth of tissue in the ears. Can it happen in the nose inside as well?
We see overgrowth of tissue um, uh, potentially in any location. So if kids have the capillary malformation on their arm or on their leg, as well as on their face, you can definitely have overgrowth of the bone. It appears to be in Sturge-Weber that the overgrowth is most prominent in tissue that doesn't have a lot of firmness to it or a lot of collagen in their dermis. So, and this is just like my observation over the years, but it holds true. So lips and like kind of the soft tissue around the ears, a little bit in the nose as well. So you can think about the things that like, if you got hit with a baseball in your lip, it swells up really fast. So those are the areas where I think we tend to see the most dramatic overgrowth. So even in the same patient, you won't see a lot of changes in the forehead, but in the areas where there's a lot of pressure and gravity and there's the tissues kind of soft, I think over years we see a little bit more overgrowth in those regions.
Annette writes, is there an age when you see growth of the birthmark? Does it happen to all Sturge-Weber patients? In other words, is there something we should prepare for?
Yeah. I think there is the different locations, but there is quite a bit of difference in my experience, just among patients. So even if they have the same mutation, so this is something I don't understand. So they have exact same mutation, two different patients, and some patients have a lot more overgrowth. So there's other things that we don't yet understand. The other thing that's really fascinating is that it appears that the cells that carry the mutation are blood vessel cells, but we sometimes see the bone overgrowing. And I don't understand why the bone's overgrowing if it doesn't have the mutation. So there's still a lot to learn, but I would say there is a lot of anatomic difference. And then even among patients, there's a lot of difference. So I have 40-year-old patients that have very little overgrowth, and then younger kids that are 10 or 12 that have a little bit more. So I don't quite understand why we see such big differences. I do think that the overgrowth doesn't just like all of a sudden start. So for patients that have a lot of overgrowth, they just seem to like always have a lot of overgrowth. So there's not like this age that all of a sudden you're going to have this overgrowth. So if your child or family members, 10 or 11, 12 years old, and there's not a lot of overgrowth, I wouldn't predict that there would be a ton in the future. Probably around hormone, we see a little bit more, but it tends to kind of go steady. So either you have it or you don't, or it kind of it appears to be that there's something, about patients that would predict that.
And there's a question further down just asking, is there any way, and I always love this question because I want to know too, can we prevent it from happening?
Yeah, I mean, and that's where I get
Oh,
really excited about some of the research, Julia, because in the past, I just was taught, this is a birth defect and we just need to try to destroy it with laser or cut it out. And now that we know the gene defect, and we can tell in our lab that those cells grow faster because there's a signal turned on, and that we can, use medications to stop that signal. And so I do think we will be able to prevent that. But maybe we can even reverse it. Like, I don't even want to stop there because, maybe, if we turn the signal off, and quite frankly, we've seen that in other vascular anomalies where we are using drugs, that by turning off the signal, not only did we prevent things, but we reverse things. And that just blows my mind and is so hopeful. So that's really a little bit about what this slide is some of the research that we're doing. It's interesting to find the gene, but it's much more interesting to find what that gene does and how that gene alters the tissue. And then we can use very sophisticated science to put that into databases and see, that can predict which chemicals or small molecules or drugs might be able to stop that signal. And so when you look here, this is one of the projects that we just submitted to the NIH, where we're going to do the genetic testing on the patients, which is our first aim, but then we use a thing called spatial transcriptome so that we know that the GNAQ gene is mutated, but how does that change the skin? What's happening in the skin? So we look at what's called expression patterns, so RNA expression patterns that can tell us what's being upregulated and what's being downregulated. And, this study, we're finding calcium signals are upregulated. Well, that makes perfect sense because they have calcium deposits in their brain. And Dr. Loeb was talking about treating with calcium, right? Like, so that really supports, that's coming together of the research and some of the things that people are trying in patients. And then aim 2 is we have these little tiny microfluidic chambers where we can introduce the GNA mutation into the chamber, and we can see that the blood vessels grow abnormally, which is here. And then we can drip drugs into those chambers and see if we can correct some of those changes. And then finally, we have similar where we can alter the DNA in our mice model to begin to look as well for medications that work. We had here's the spatial DNA, which I don't know if there's any nerdy people here, but you can kind of see just all the different colors are different pathways that we could be targeting. And we want to look, this is a little slice of the skin. And so the abnormal blood vessels, all these white things are abnormal blood vessels. So we want to kind of look in this blue region to see what kind of changes are happening in those cells that are causing those blood vessels to grow. And then once we know what proteins are changed, then we can look at kind of medications to change it. And then here's just a quick picture. I hope this doesn't offend anybody, but of when we altered the DNA of mice in our lab with the GNAQ mutation. And you can see on this side, we're having, very dilated and that kind of hypertensive blood vessels in the skin of the mice. And then we can try to reverse those DNA changes, even with like CRISPR. So maybe it won't be medications, but maybe we'll have gene therapy that can come in and change the code. That would be even better because you wouldn't have to take a drug every day. So with the mouse model, that's kind of what we're working on is, once you have the DNA, can we then go in and change that code and fix that mutation so that those blood vessels aren't overgrowing as well.
That should give us hope.
I know, I'm excited. You can see I'm like, really excited about our lab has almost wholly, committed to the GNAQ and GNA11 changes just because we have, so much access to tissue because of the skin. And we've gotten really smart people that, do gene therapy interested. We just got a big donation. It was like last week, Julie, that we're excited. So we have a new professorship in rare skin disease, and we'll be hiring somebody to work on gene therapy for some of our vascular anomalies and GNAQ. So we're really excited. So hope. And I also can answer questions about laser too, if folks have that.
Excellent. I know the one question they had was if you take a biopsy, does it scar? And then once you have that, what gene mutation one has, can that help treat them? If yes, how so?
Yeah. So the biopsy does leave a little bit of a scar, and so it's very small. Like I said, maybe a little bit smaller than that. So if we do, we like to take it not on the face or like behind the ear or in the scalp. In the scalp, we don't really leave much of a scar. So, but that is important. You don't want to take it right in the middle because that would leave a scar. Um, it depends which gene. Right now, for the GNAQ, we don't have a targeted treatment. And so when I talk to my patients, and if I'm pretty sure, because I can kind of look at the shape of the birthmark and fairly certainly know if it's GNAQ or GNA11 or the PIK3CA. It probably won't change treatment right now, but in the future, I think it will, and that future hopefully won't be too far out, so that you'd want to, before you would try a medicine or before gene therapy, you would have to know your specific gene. So I would say, if your insurance company is covering it, if you have a good spot to get it's helping science, and then you'll be kind of set up to be in clinical trials when they come, because we probably will, my guess would require knowing the gene therapy. But there's, no urgency right now.
No, but you would make the other scientists very excited too, because I know Nathan Lawson gets very excited when we have all of that too with his zebrafish. So we had a question here. What causes the swelling and malformation in the face? Does laser prevent this from happening?
Can you repeat the first part, Julia?
Yeah, what causes the swelling and malformation in the face?
Yeah.
And sometimes I think this might be with this question goes with, after a laser treatment too, you see a lot of swelling at first.
Mm-hmm.
And I guess how does that work? And does the laser prevent it?
Yeah. So I think that over years, the swelling and the overgrowth is probably caused by dilation of the blood vessels, and then like increased pressure in the blood vessels, which then, kind of push the skin out and up, and they become more raised. It becomes darker in size. So there aren't necessarily like more blood vessels, they're just like dilating, which is very different than other vascular anomalies where we see the blood vessels actually, growing and you have more of them. It's more, this is just more like, I think about it like hypertension of the skin in the blood vessels. I think the larger they get, the more hypertension they have. So that's where laser probably prevents some of that. So we know after, I've been doing laser for 30 years, and I know the kids that I had treated, they seem to have less of the, darkening, and maybe a little bit less of that tissue swelling. They have less of the blebs because we've kind of just kept killing the big blood vessels. They grow back. We know they come back, but instead of like getting bigger, 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 they get bigger, they get a little smaller, and they get bigger again, they get a little bit smaller. So I don't think the laser cures it, but it probably is helping, and kind of like a band-aid approach to preventing some of that. Um, in my opinion, yeah.
Excellent. I have room for two more questions. So I'm going to ask you the one question that's in here. I do want to just go back to the medication piece, because there's two questions about the medication being available, and or should they be talking to their doctor about this? Is this available yet? Or
No.
it's still coming, right? Yes.
Yeah,
Or
yeah.
is
So um, a little bit of the frustrating part, at least, is with some of the other genes that we've found in vascular anomalies, we were able to very quickly find medications that were already available and repurpose those medications. That is not true for GNAQ. And so that's why my lab has focused on that, because we have a lot more learning to do about that pathway than some of the other pathways. And there are like a few ideas that we have, but those are like molecules, and they haven't been developed for other diseases. And so there's a lot of like the drug development kind of thing. So we need to, I think still need to go slow to figure out, um, what might be the best drug. And all of us kind of have ideas, but none of them have even been tested. And then, there's a whole drug development thing. So still, pretty far from where we can start to treat patients, but a lot closer than we were even 2 years ago. Because Julia knows, like, now there's like 3 or 4 or 5 labs around the country that have models that we can start to test drugs. We didn't have that 2 years ago. We didn't have that a year and a half ago. So slow, but definitely forward progress.
And I think everyone on the call, just remember 10 years ago was when we discovered the gene. So we have come very far in a very short period of time, which is very, very exciting, especially being that we have a couple of very new patients, new families on the call today. I know you're gathering everything and getting everything you can as quick as you can, but we have some really, really fun people on this call today that just are doing some really fun things. So keep that in mind. And then the last question for you, Beth, if you don't mind, there was a paper that was put out on social media yesterday. It was from Roy Geronimus, just stating, I guess, laser treatments to be done more often and having quicker and higher success rates with babies. I guess, what is your feel on that?
Yeah, I would say I've had 3 different answers to that question over the years. So initially, I just because I've been doing this a long time, doing laser, I did not believe that treating earlier was better. And I felt so bad for parents who felt pressure that they had to make decisions about laser early on. Um, I Now that I think we know a little bit more about the science of what's happening in the skin with capillary malformations and port wine stains and laser, it does make some sense that when you laser babies, their epidermis is thinner and you may get a better result. Um, and be able to, the idea is you want to kill like those mutated cells, which we don't do with laser for sure. Like, I don't think anybody's ever cured a port wine stain. So, but I do now believe that you would probably get a better effect because of skin thickness in some areas, particularly in the face with younger. We've always gone, back and forth with like how quickly to do the laser. I think the main thing is you have to get rid of all of the hemosiderin from the prior laser treatment. And that, in my opinion, does take at least 3 weeks, probably closer to 4. I would never want to do laser on somebody that wasn't like at the perfect, point of they're going to get the maximum benefit. And if you have some of the iron in your skin, that potentially could block the laser. So I think waiting another week or two when all of that's healed up is a good idea. And that's just kind of using the science of laser. The studies of to test these facts are all flawed. Both, the ones that show it works, better earlier, and the ones that don't. So I think it's a very hard study to do. So I think using the science of physics and of how the laser was designed, it is good as well. So, and everybody's decision about laser should be individual because every baby is individual. Depends how far you have to travel. It depends on the location, finances, but earlier is probably a little bit better.
Excellent. Dr. Drolet, I thank you as always. I think it's fantastic you spent the time with us today. And 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 one thing I don't know that I said in the beginning, she mentioned her lab several times. So it's not just that she's a dermatologist doing laser, but is also studying it very well. And that's why we love her and her team and those that go with her, because it's just a lot of fun to hear. And her excitement, you could see it right on her face today. And when it comes to Sturge-Weber, we get excited when they get excited. So thank you so much for coming
Thanks,
today.
Julia.
And we look forward to seeing you again soon. Bye-bye. All right.